has to be infected. That's the most important criteria. If the wound is colonized, looks, lot of exudate is coming, so it's probably of increased bioburden. In that, a topical or an aggressive debridement will help. And broad spectrum, if it is infected, a broad spectrum antibiotic, depending on your hospital antibiogram, can be chosen safely.
So, depending upon, so you were talking about the chronic and acute generalized approach for the wounds.
Yes, the wound has to be infected.
Yes. So first thing is, please, before you start the antimicrobials, see that the wound is infected. Antimicrobials are not like the जब भी करना है हम antimicrobials start करने. So there are various factors we have to take care while starting the antimicrobials. First thing, that it should be infected. Otherwise, there is no use of antimicrobials. Then the wound characteristics, microbial considerations. What is the flora? The earlier speaker, the earlier panelists, they were discussing about the flora present in the hospital. The patient-specific factors also, we'll come to it in the later part of the discussion. The antimicrobial spectrum, the antibiotic you are choosing, is it covering the pathogen you are targeting for? And of course, the local antibiogram of your hospital. And one thing which we forget most of the time is the cost and availability. हम लोग बहुत antibiotics या कुछ भी लिख देते हैं अपने patient को without knowing whether the patient will be able to afford that or not. So also think about the cost for the patient, and it also depends upon whether it is a community-acquired infection or a healthcare-associated infection, because the spectrum is entirely different in both the cases.
Dr. Fatima, is there any role of prophylactic antibiotics?
So we'll come to it in the later part of the discussion. Ma'am, may I request Professor Zahra Mohsin to answer this question? Ma'am, what are the factors that make your patients different and they need special attention while considering the antimicrobials for wound management?
We are dealing as an obstetrician and gynecologist. I think what we are basically dealing with a lot of young patients. So very few ones with comorbid conditions. But I think, we are only sticking to the basic antibiotics. I think I just remember I've used linezolid maybe just for 5 cases. So I think the most important thing is that whenever we are prescribing, we have to have a policy in place. Like in the department, we have a policy in place for all routine surgeries. Even for emergency cesarean sections, we are giving a single dose antibiotic. We are following up the patient, and any discharge is then evaluated, and then we decide how further we are going to treat. So I think, and the other important thing that we have to have in place, which I feel is the need of the hour, but which is not really related to wound management per se, is to have your SSI prevention guidelines in place. I think you have to make a departmental policy. Everything should be explicitly worked out and mentioned about how the team, the surgical team, what orders the surgical team is going to give to the patients. Even something as simple as a preoperative shower has to be emphasized on. So that is the most important thing that I would like to say.
Thank you so much, ma'am. As we were having a discussion, me and Dr. Ashok Pradhan in the morning, and I was just applauding the efforts of the Department of Gynecology that they have a policy and they are following the policy. So first thing is that you should be having a policy, then only we can follow that. Then other things, I think the anatomical and physiological considerations, and there's certain hormonal factor also that may be playing a role in your patients. The underlying conditions, ma'am, I would just like to ask one question is, does anemia play a role in your patients?
I don't think anemia plays a role per se in causing infection. Maybe a little bit of delayed healing. We don't, in anemic patients, we do not do a very early stitch removal. But Fatima, we work with you, and I don't think there was a major difference in infection rates in anemic versus non-anemic. No.
And the surgical or traumatic context and the type of the wound infection that you are dealing with, obviously it is same as for the other surgeons also. So thank you, ma'am, for the inputs. Dr. Ashok Ratan, may I ask you this question, sir? Key factors for contributing to the antimicrobial misuse in patients with phones.
We're now restricting ourselves to surgery. There seem to be 4 key factors. One is that the diagnosis of wound is a clinical diagnosis. And unfortunately, there's not an objective diagnosis. So it's an eye of the beholder. That means the solution to that will lie if we can get a rapid test which will tell you whether it is diseased, whether it is infected or not infected. And we have already discussed that there is colonization. Colonization will be the first, there is contamination, then there is colonization, then there is infection, then that can spread. But if there was an objective criteria in which the surgeon knows that this wound is infected and not infected, at the moment it lies on the eye of the beholder. The second one is that they fear that it will get infected. And of course, as I've always been telling everybody, that every surgeon wants that is excellent surgery is not infected. So it's the fear that it might get infected, so he does things and he needs help in saying that, sir, this activity will lead to increasing infection rather than decreasing infection. And I think we have failed in giving them enough evidence. We failed to give evidence that will convince them, because I'm convinced that they do not want any infection. If they don't do what we feel, as microbiologists we feel in our rooms, that this would be best. If they don't do, that's because we have not been able to generate enough evidence and convince them. The third part is that all of us learned a little bit of infection, and microbiology is taught in a different way altogether, not relevant to clinical practice. Subsequently, it is left to the retailers to tell us what works and what do not work. So I think we have to then help them gently understand where antibiotics will work and not work. And fourthly, it is patient's perception. Some patients, not everybody, some patient feels that antibiotics are must, while others feel weak. So these 4 factors are the one which contribute to misuse or overuse of antibiotics.
Thank you so much, sir, for highlighting the points. So as we say, there is sometimes a lack of diagnostic precision. It is a fault, but sometimes it happens, and it's because it is a subjective thing. And please remember that every discharge is not infection. There is sometimes healing discharge also. We have to distinguish between the discharge which is because of the healing of the wound, which is a natural discharge, from the purulent one. And I very commonly say that a good surgeon or a good clinician has to be a good microbiologist. You all must have the eyes of a microbiologist, so that you can identify the infections. And of course, proper specimen collection. And sometimes fear also, the microbiologists also are at fault when we take too much time in giving back the reports. So if we give you the reports in proper time, reducing the turnaround time, that will also lead to decreased abuse of antibiotics and overemphasis on prophylaxis because of the fear factor that sir was mentioning, and sometimes as external pressures. Again, sir has highlighted this. So let's move on to the next question.
Dr. Fatima, I have a question to Professor Ashok Ratan. That fear factor, why surgeon is they are in fear?
So the fear.
There must be some other factors which is making the surgeon fear.
Because they're facts.
Because again, we are not well, satisfied with the hospital setup,
Yes,
the sterilization of the equipment, the patient status, the conditions in the wards, and that's why the surgeons, perhaps, they are.
So the solution, one solution, of course, for diagnosis is that there is a rapid test available, which is looking at proteases of the bacteria. And that is a rapid test which is known as wound check, which is now available, which in 20 minutes time will tell you whether the wound is infected or not. That is one. Then of course they have a handheld camera which can then tell you whether there is gram-positive contamination or gram-negative. And if you do multiple photographs of that, you can then see whether it's increasing or not increasing. Because contamination is just like that, and then once the bacteria has taken hold, they'll keep on increasing. So you can, that means people are working to make sure that they help give evidence. Microbiology will not be able to help because it takes 48 hours for the information to come. While you need the attention now, you need the results must come to you within 20-30 minutes, so that while you're cleaning up, you know, yes, it is infected, I need to now add antibiotics, or no, it is not infected, I can leave, or I can do local. So there is movement towards that. And of course, I think everybody has given long list of what are the things we have to do before the surgery is performed. So that it's sticking to those checklists which WHO as well as CDC has circulated. If we sincerely stick to that checklist, chances of infection will decrease.
Sir, yesterday when I was sitting in this conference hall, there was a surgeon who was saying that a surgeon who fears is better than a fearless surgeon. और मुझे लगता है वो सही है, ज़्यादा fearless होना भी कभी-कभी. So we have to set a boundary line कि कितना डरना है और कितना नहीं डरना. So everything in a limit is good.
Probably you are talking about the cutting part.
Sir, infection से भी तो डरना चाहिए. Everything in a limit is, I think, good. Beyond limit it is dangerous. So may I ask the two surgeons sitting here, what is the recommended surgical antimicrobial prophylaxis and what you are following in your practice, ma'am and sir?
For cesareans, we are using a single dose cefazolin, which is given within 30 minutes of starting. Now often in gynae, especially in obstetrics, there's a lot of chaos. So sometimes we are just shifting immediately. So we insist that at least you give the antibiotic shot at least before cord clamping. If you are not able to, especially for cases like cord prolapse, which have to be shifted within minutes. So at least that single dose we think works wonders. There has been a study in the department, so I'm talking about the hospital data. We had an infection rate of about 10%. Most of the infections were either staph or E. coli, very strangely, the second most common organism. I think it's just fairly comparable with other places. Then, just like we were talking about fear, for hysterectomies, we use the third generation ceftriaxone, and we just give prophylaxis for IV prophylaxis for at least 24 hours. That means we also repeat the dose 12 hours later, and a lot of us continue with oral also, which we give for about a week at least. The fear factor is there, to be honest. As per international guidelines, they recommend a single dose prophylaxis, but for the reasons we've been talking about, anemia and the situation and sterilization issues, for hysterectomies, especially vaginal hysterectomies, where we are doing a repair surgery along with in prolapse, along with just a simple hysterectomy, we are definitely using it for a week minimum.
Welcome to sir. So ma'am, the infection rate you quoted 10%. I think we brought it down to 3% when we were doing the Laksh initiative program.
And was documented on a culture, is we took it as an infection. There were pseudomonas also, but we did not report any protein.
May I ask the same question?
This is more or less at present very stable and clear. There are guidelines there that it should be a single shot for surgery, and surgery is classified into type class 1, class 2, class 3, class 4. So most of the class 1 surgeries are thin and elective, so you need a single shot for that. And sometimes people don't, I mean, I'm not saying that we are not going into the debate, but some people don't give an antibiotic if it is a very minor surgery.
For clean surgeries like lap chole, etc.
One single shot,
Yeah.
single shot antibiotic.
Antibiotic may not be recommended also.
Yeah. Now, class 2 and class 3, the prophylactic antibiotic can be continued for 24 to 48 hours after surgery, depending on the situation. And a class 1 surgery, lap chole is a class 2 surgery because there is a controlled entry into a tubular structure. So, usually another shot of antibiotic post-operatively can be given. The problem happens when there is a gallbladder rupture, puncture, and immediately if it converts into class 3 during surgery, so we can extend it to up to 72 hours to see whether otherwise the antibiotic can be stopped. Class 4s are usually dirty surgery, and these surgeries are mostly emergency surgeries. So the antibiotics, before the surgeon comes into picture, the emergency medicine persons have already started the antibiotic. So that becomes almost a therapeutic antibiotic to be continued after surgery also. So prophylaxis actually overlaps with the therapeutic part of the antibiotic regimen. Now, there is an interesting situation here. The definition of the class 4, which is a dirty surgery, is given by already infected. Yes. Now, there is a query here on which we studied and we are yet to see the results at our place. Suppose the patient comes within 6 hours with a perforation peritonitis. So the infection has not set in, but by definition it's a dirty surgery. But actually the picture is of a class 3. So what should be the antibiotic regimen in that case? We took help of the Procal to register, see the effect in these types of patients. After the surgery is continued serial procalcitonin estimation and clinical FHA estimation. An interesting result. So we have a tendency to, for all perforation peritonitis, give antibiotic for 7-10 days. So the Procal rapidly went down within 3 to 4 days. And it was a sham study, nobody stopped antibiotic. But the question, and this is going on for the last, if you follow these, the WSCS guidelines or other guidelines which are there, they are actually now is asking the question that these types of patients who are not actually getting infected. So perforation peritonitis, there are various phases, you have a phase of chemical contamination, then elusive phase, and followed by bacterial peritonitis. So that is the dirty part. Then just simple spillage makes it class 3. We still don't know when the class 3 gets converted to class 4. That is purely clinical indecision. So this is an area window which is slightly undecided, but for the safety purpose, as sir had said, nobody wants to play with their patients. For the safety aspects of it, it is always better. People always follow that they should be safe, and that becomes ethically also incorrect to subject them to randomization sort of thing. Yeah.
Thank you, sir. I hope your question has been answered. And when we go back after this conference, my urge is that at least we start following the guidelines for the clean and class 1 and class 2 surgeries, and then we can follow it.
True, and we are following the same guidelines because unless we will classify the surgical route, we can't decide about that. Right?
I'll tell you, sir. What happens is, an average surgeon doesn't classify the surgery. Second, the surgeon has to ask himself, am I giving the antibiotic for prophylaxis or therapeutic? If the answer is therapeutic, and if you are convinced that there are evidence that it can be therapeutic, it should continue. The moment the answer is no, I don't know why I'm giving it for, so probably you're giving it for prophylaxis. So it should stop as quickly as possible.
That's true. In a clean contaminated type of wound, we go for the prophylactic. But for the contaminated and dirty wounds, we generally start like a therapeutic, not the prophylactic.
So then the question becomes what antibiotic to give. Because, prophylactic also, because I think we have been using cefazolin everywhere in the world. But in that they will always say that choose your prophylactic antibiotic depending upon your local antibiogram. So if it is prophylactic antibiotic, your aim should be zero infection, not 10%. Your aim is zero infection, and if cefazolin is not getting you zero, then that means the aim of cefazolin is fine. It's good for West, where everything is spick and span, where infection is caused by self-bacteria, and the bacteria that cause infection is Staph aureus in the skin, Staph epidermidis in the skin. So cefazolin, you're not going to use for anything else. Cefazolin is good. You give one dose, it works for 3 hours. If your surgery is less than 3 hours, you don't have to give anything else. So for the West, it's fine. For us to cut and paste without advice, looking at our results is something which we have missed the bus. Just before coming, I looked at whatever ICMR says or CMC Vellore says or NCDC says. Everybody is only cut and pasting that gives cefazolin, but it should be decided on the basis of your local antibiotic spectrum. So I would urge everybody that for every prophylaxis, you look at what are the bacteria which are escaping, and is it possible for you to cover as prophylactic. Of course, one thing I also noticed was that after the Americans attacked Iraq and they were there for some years, when they went back, they found that the veterans suffered from infection which is Acinetobacter. And they said Acinetobacter was involved from those veterans who were exposed to dirt in Iraq. So their conclusion is that Acinetobacter is a sign of how dirty your ICU is. And so if your hospital has a lot of Acinetobacter, please make sure that you're not going to get success till your ICU is spick and span and like a 5-star hotel. I served for some time in Ras Al Khaimah, where everything outside was a desert, but the inside of the hospital was so good that we had zero Acinetobacter. When you come back to India, every place Acinetobacter is causing problem. It's because of dirt. So unless you attend to that, and as Sir mentioned, that it is the infrastructure. I'm scared of losing my good work because of the lack of infrastructure. But pinpoint the fact you require and aim for zero infection. If it is prophylactic infection, if you're doing clean surgery or clean contaminated surgery, it should not lead to infection. Then
again, sir, what we feel that it's all dependent upon the site also, where we are operating. If we are operating in the perineum, in the groin area, in the dirty area, in the anal regions, again the resident bacteria, the resident flora is different from what we are operating on the breast, on the neck. So cefazolin is purely for the gram-positive. So whether that will be effective in the perineum, in the lower abdomen, near the mons pubis and like that.
So we have to give an anaerobic coverage for this.
So again, yes, so that is again
we
important.
We have guidelines for that.
Right.
But sir, we have in our department done a comparative study between cefazolin and ceftriaxone. The reason being the same as sir pointed out, that we feel that we are just naming the West. But the evidence that we found was that cefazolin was as good as a 2-gram single shot This is the study that was done by So we found them comparatively good, although we expected our research question was except right
Dr. Pal.
Sir, we have to do it according to the resident floor. Yes, sir.
But one thing I would like to ask the microbiology, sometimes we are in a phase, we are sending regular cultures, and there was this time I remember a couple of years ago when a lot of culture reports said media, and I mean it just kind of popped up out of
Corynebacterium, yes.
Yes, Corynebacterium.
Steroids.
So then we as a surgeon, we are at a loss when we have this thing. One, then we kind of overlook it, and then another, and another. So,
Actually, diphtheroids, they are considered as non-pathogenic organisms, but sometimes depending upon the amount of the pus cells they are present and the number of these diphtheroids they are being isolated from pure culture, then we consider them as pathogenic also. We grade them accordingly. And then we send the report after we consider them pathogenic. Otherwise, जो आपके पास NPO वाली report आती है जिससे भी you people are not very happy. So these NPOs are those diphtheroids and those all other organisms. Most of the times we send them as non-pathogenic organisms.
but we say that it is pathogenic and you are sending the sensitivity report, then we are supposed to give.
Then you have to clinically correlate whether your patient is having, because when you send a sample to us, we consider that your patient is infected. So you have to go back, review the report, whether it is correlating with the clinical condition or not.
Because we cannot ignore diphtheroids also every time.
Yes, okay.
Because Corynebacterium genicum, for example, is a skin commensal. But if found in infection in your pus samples, it can have high mortality. So that is why we always don't ignore even diphtheroids.
We judge according to the number of pus cells present in all. Ma'am, again a question for you. Do you think, Zahra ma'am, do you think that specimen collection has a role in correct antimicrobial therapy? Yes, we had a discussion on this yesterday also. It does play a role. So shall we move ahead with this question? Yes, it helps in accurate pathogen identification and tailored antimicrobial therapy. But again, it is ignored. It is not given much importance because of lack of awareness and training, time pressures, अभी भी pressure है हमारे ऊपर, reliance on the medical therapy, resource constraints, and perception of the laboratory role. Sometimes, like जब हम NPO देते हैं तो हम NPO नहीं देना चाहते मैम actually because we are not very famous for giving NPO reports in contaminated, but they do play a role. Professor Ashok Ratan, how can rapid diagnostic tests be integrated into wound care for targeted antimicrobial use, especially in resource-limited settings like ours? उधर भी है, इधर भी.
Rapid diagnostics will be highly useful both for initiation, but I think rapid diagnostics, as I told you, there are two rapid activities becoming available, and maybe you should explore whether they'll be useful in your location. That is the wound check, which will indicate whether the wound has protease, and that is a lateral flow. It will give you results in 20 minutes time, or the camera which shows whether gram-positive or gram-negative bacteria is there. And in YouTube, you'll find that there's mention of this camera, in which they've also tried to say that had I swabbed, I would have only reported Staph aureus in the center, and Pseudomonas in the center and not Staph aureus in the periphery, because swabbing is not a good way of collecting, because you want to differentiate between colonization and infection, and so it's been suggested that you should have punch biopsies and you should do quantitative culture. And if the bacterial load is more than 10 to the power 5, then you should consider that it is infection. If it is contamination, then maybe local antibiotics or cleaning would do. But I think these biomarkers could be useful in deciding when to stop antibiotic. I think Dr. Basu has mentioned something about procalcitonin falling. So there are indications. I would not suggest that you use procalcitonin in starting your treatment, because that is your clinical judgment, and procalcitonin is not that reliable as initiation. But when to stop, there is evidence that procalcitonin falls very rapidly when adequate bacteria is there, and if the values are less than 0.2, then you should stop antibiotic. If it is more than 1 and it continues to be more than 1, then please continue your antibiotic for whatever you feel, provided it is high. When I was in Medanta, we started the liver transplant program, and even without surgery, first day, patients would have 30 or 40 nanograms per ml of procalcitonin. Then they'll start falling. So trauma also leads to procalcitonin increase. So I'm not suggesting to you that procalcitonin is specific. It is not done partly because it is sent out. So now they have point of care quantitative quantitative procalcitonin, and I think in ICU to decide when to stop, that might be something that might help.
Sir, very rightly pointed out, but the thing is we are a resource limited setting और हम लोग क्या we were using procalcitonin in an ICU जो हमें बंद करना पड़ा because our patients were not able to afford.
No, let me be clear in this. I remember when I was in AIMS, there was some visitor came from New York, from New Zealand, and we went to the ICU to show what we were doing, etc. with Dr. Collis. And then he says, I noticed that your doctors don't hesitate to give meropenem left, right and center, but they hesitate to wash their hands at the right time. So what we must know is we must talk about cost effectiveness. The cost of meropenem is 3,000 or 4,000. Cost of procalcitonin should be 500 rupees, point of care testing. So if you use it for the right active, then it will be, there is a study in the West where they said they decided procalcitonin led treatment, and they saved $6 million in 1 year by using procalcitonin. So you will not lose money, you will save money for the society and from the organization if procalcitonin is used wisely.
I hope I may be able to convince the clinicians for this. And as you were mentioning, sir, the point of care, this camera, we are having this camera actually, and one of my students presented this work in your poster presentation also. It gives you the picture, exact picture, whether the gram-positive or gram-negative bacteria are present, so that you can start the empirical treatment accordingly. And I also want to emphasize the role of gram staining. बहुत ही simple, सस्ता हमारी resource limited के लिए है. But if you collect properly and you have a side lab which can tell you immediately कि gram staining में क्या bacteria है, you can start your treatment. Because we have to think according to the resources that are available to us. Ma'am, Dr. Tohina, ma'am, a question for you. What are strategies are most effective in dealing with the biofilm-associated infections in chronic wounds to minimize resistance?
Right, biofilm is a big problem, but what I want to say, all biofilms are not bad. So it's a decision whether I need to remove the biofilm because of infection. And diagnosing infection in wounds is totally a clinical entity. So for removal of biofilm, what is best is debridement. This mechanical debridement, the best. You can use enzymatic debridement, as shown in one of the talk today morning, pepsin of local enzymes made in gels which are put on over. There are also topically applicable probiotics like the Lactobacillus species Plantarum mostly, which actually stops the forum sensing because the biofilm organisms have a very good network of communicating among themselves and these inhibit that communication. Besides, there are also a lot of nano research going on, nanoparticles which exactly enter the biofilms and deliver the antimicrobials. And because my center also works on bacteriophages, so that is another upcoming field, though limited in use in the humans till now due to ethical issues, but local application of bacteriophages also help in disruption of biofilms. But it is best to debride actively in proper way, but only when there is necessity to remove the bacterial biofilms.
So debridement is the best policy if it is possible, but sometimes there are certain implants, etc., which cannot be removed. Then we have to go for other options like enzymatic proteases, etc., lactobacillus, and nanoparticles and bacteriophages, which they have certain ethical issues. So thank you, ma'am. How can local antibiogram, Dr. Ashok Ratan sir, how can local antibiograms and surveillance data shape better antimicrobial choices? I think we discussed this also, so we can just move ahead. This, as we know, this can help us in local antibiotic policy and empirical treatment. Dr. Som sir, how effective are the newer wound care agents like antimicrobial coated dressings in reducing systemic antimicrobial use?
Okay, the two things. One is antibiotic, the other is local antimicrobial. So those are mainly, the local ones are mainly used to prevent proliferation of bacteria. So it is something of a, you take control of the situation. And the antibiotic is used only when there is a wound infection. So if we are using local antibiotic ointments, creams, powders or whatever, that's not right. That has now been rejected. It should not be used. What it does is silently, without our knowledge, develops resistance to the systemic antibiotics which are being used locally. It should not be used. Straight away it should not be used. You can use a local antiseptic or local antimicrobial which stops bacterial flora from increasing bio